Hello, everyone. My name is Nick Housley, and I'm the Director of Clinical Research and Development at Motus Nova. And for those of you who are not familiar with Motus Nova, we are a medical robotics and technology company based out of Atlanta, Georgia, and we were founded in 2013. And my main goal today is to talk to you about our tele-rehabilitation systems, the Hand Mentor and the Foot Mentor, and to give you some insights to our process and what we've learned over the years of translating from clinical science to a commercially viable robotic system for stroke rehab. So I have three primary goals for today. To give you some understanding of the rationale for why at-home robotics are needed in stroke rehab, give you some insight into our current robotic systems and their evolution over time, and tell you some of the lessons that we've learned over the years of translating from the clinic to a consumer product. So our central motivation is to address the needs of stroke survivors. And at present, there's around 80 million individuals across the world who are chronic stroke survivors. And at present, there's around 4 in 5 or 80% of those individuals need additional rehab. And our best way to address those demands, those needs for functional impairments are to use physical and occupational therapy services. It's kind of our gold standard. And so when you do the math, there's really a large need of stroke rehabilitation. And then the next question that kind of arises from this is how well are we doing to address that need? And so for the sake of scale and just for simplicity in numbers, because we do have good numbers from the United States, we'll focus there first. And so at the United States, there's around 7 million stroke survivors right now, and around 4.6 million of them have mild to moderate symptoms that are good candidates for this high intensity repetitive task practice that is known to be sort of the most effective way to improve their function. And so if you do some simple arithmetic there, based on the number of hours per day, we can figure out that on a daily basis, we need to deliver around 14 to 23 million hours of rehab. And the next question that arises, of course, is how well are we addressing that need? And when you consider around the 350,000 PTs and OTs across the country operating at full utilization, 100% efficient, 8 hours a day, we're only matching around 1/10 of that need, around 2.8 million hours. And so you can see that we have quite a large mismatch there. And in fact, the story is much worse because there are additional factors at play, some of which are highlighted here on the right-hand side, such as the geographic restrictions, scheduling burdens, motivation, and most salient of all this last year has been infection risk. And in fact, the story is even more complicated than this because not all of those 350,000 PTs and OTs are treating stroke survivors every single day. And so in fact, our numbers are probably even an overestimation of the true capacity to meet that demand. And so what this means essentially is that there is a large unmet need. And our contention is that we need innovative solutions to address this incongruity. And so at Motus, we propose a solution to involve technological workforce multipliers. And this is basically something that takes an hour of PT or OT time and amplifies it, either several-fold or even in certain cases an order of magnitude, which might be the case that we need to address this large need. And so robotic devices aimed at delivering this high quality repetitive task practice, this rehab, is one of the primary tools at our disposal to help address this problem. And so due to numerous other factors that block access to rehab, our solution at Motus is designed to work effectively at the home, at the stroke survivor's home, where they can either self-direct their care or work with a skilled clinician remotely to kind of see the device's operations and leverage artificial intelligence algorithms to assist in treatment progression, essentially filling the gaps when the skilled provider is not available. A great example of this is filling in the gaps between those 2 skilled therapy sessions a week. And so to do this, to accomplish this rather, our systems build on around 15 years of clinical and scientific foundations, ranging from basic studies of how the brain changes after use with the Hand Mentor to large multi-site trials testing the efficacy in a dose equivalent usual customary care fashion, and even to a large nationwide implementation study. And this latter example is especially important simply because the capabilities to successfully operate without the need for real-time oversight is an essential component to address the gap that I had mentioned earlier. And so currently we have 2 robotic systems available, the Hand Mentor and the Foot Mentor. You can see them playing on that video right on the right-hand side. As you can tell from the naming convention, the Hand Mentor is operating on the upper extremity and the distal hand and the wrist, and the Foot Mentor is operating in the lower extremity to help around the ankle and the foot. And so that video provides kind of just a quick overview of how they operate and how they're donned and sort of the gaming interfaces that are present. Fundamentally, the devices operate on the same principle, though. They can sense movements, muscle forces, and those are provided by the stroke survivors. And then it conditions a virtual Exergame environment on that user's conditions and their capabilities. And so then the user, the stroke survivor in this case, engages in that interactive environment that requires movement to successfully operate it. And so in addition to just being sensors, the hand mentor and the foot mentor can also provide dynamic assistance based on pneumatic actuators that can operate in numerous ways, but they're typically used in two. The first of those is to help individuals initiate movements, and the next is actually to amplify movements if they have restricted range of motion. And so right now, there are two kind of ways that stroke survivors can actually utilize the hand mentor and the foot mentor in the home. The first of those is a simple delivery method where they're using this in the home independently. This is kind of self-guided care. And alternatively, they can engage with a PT or OT for tele-rehabilitation. And so the image here on the right kind of gives you an actual representation of what one of those sessions looks like. And so this is sort of a typical setup where the individual has the exoskeleton donned on their left-hand side, which is connected to that peripheral device, that monitor that displays that biofeedback. And on the right-hand side, you can see a second screen there, which actually shows the skilled provider. And this gives that indication of being in a real-time session. And so let's quickly just take a look at the sort of dynamics of the situation here. And we'll first start off with the patient's perspective. And so from the patient's perspective, the computer program translates the kinematic and kinetic signals to movements of an avatar or controller on the screen. And they can also interact with that screen either by touch or by listening to those audio cues, in addition to, of course, the visual cues that are being presented as well. And so these two videos on the right and left are actual views of a stroke survivor engaging in their therapeutic exercise. And then so for the purposes of this presentation today, I generated these 3D arm and hand representations that are moving. But these are actually conditioned on real movements from a stroke survivor and kind of show the simultaneous movements and avatar dynamics to kind of tell you how the mapping of the movements onto the Exergame environment happened. And so I selected these two games specifically because they provide two levels of instruction, from sort of an explicit to a more implicit type of instruction. On the left-hand side, we can see that the arrows throughout gameplay are showing the desired movements. And then on the blue bar on the right-hand side, it actually demonstrates the amount of completion to kind of give you some indication about how much more you have to do. And on the right-hand side, we can see much more of an implicit style of game, in which the game, sort of the goal is to simply score as many points as possible. And we don't really tell you exactly how to do that, but you have to figure it out throughout the learning process. And so on the right-hand side, you can actually see that the individual is controlling the right-hand side, that blue paddle, and to figure out that they score points when they are able to actually knock the ball back past their red opponent's paddle. And so from the provider's perspective, when a stroke survivor engages with the PT, that provider is actually able to log into that device from wherever they are across the country or even in the state and watch not only the actual screenplay through a viewport, but also see the data. You can see here's a quick actual screen capture from our provider dashboard. That's the means by which that provider controls the robotic devices. And so these multiple data streams, whether it's the real-time video and audio to the kinetic and kinematic signals, help the provider perform remote evaluations and develop treatment plans that can operate when that stroke survivor is working independently. And the provider also has the ability to remotely generate prescriptions by modifying certain exercises and their sort of parameters, such as the total time or also the work to rest ratio. But the provider can also leverage the artificial intelligence that Motus has developed, and we've learned throughout all of our stroke survivors playing these games to help kind of fill the gaps when they're not able to operate and work in real time. So it kind of does the sort of fine-tuning adjustments. And it also is able to be conditioned on what the provider thinks is most appropriate for that individual. And so to give you some of the sort of the evolution here, we of course didn't get here with the tap of the fingers. It took us a long time. And in terms of the device implementation, we actually started with a much more bulky, costly system here, which was originally called the Rupert. And we realized early on that this was actually incredibly hard to use, not least of which was because of the cost, but it was really, really hard to use. It required a couple of people to actually don and doff, and it was just not going to work well at scale. And of course, it didn't actually have any biofeedback or virtual environment. And then we extracted, rather, the most distal aspects to focus on just the hand and the wrist. And we incorporated some nominal UI, which was just frankly terrible at the moment. It was just a series of LED diodes that kind of gave you some indication on where you needed to move. Then, of course, we transitioned into a much more clinically appropriate tool that we used in the early to mid 2000s. But in all these cases, it actually required the real-time oversight of a clinician. Outside of that last study that I did when we did the large implementation trial, it always required a skilled provider to be there working in real time for the studies and for the interventions. And so these really weren't scalable solutions. And so we had to really figure out artificial intelligence algorithms that could operate and help individuals do their rehab independently, and which is one of the reasons why we actually settled on the solutions that we have now and we're deploying now. And so throughout this process, we've learned a lot. So I want to kind of just highlight a couple of these things for you guys. The first of those is of the utmost importance, and all stroke survivors and their care partners care about this. And effectively, this needs to be the devices, the interventions have to be efficacious. They have to work at inducing positive sensory motor changes and ultimately lead to function. In terms of the UI, it needs to be easy to use. It needs to be easy to interpret because the onboarding process is non-trivial, especially if people have different levels of technological literacy. So being able to understand how to operate the system independently is the utmost importance. The biofeedback, the gaming interfaces have to be intuitive as well. It needs to be mapped on in meaningful ways. It can't have these crazy mappings, especially early on, because individuals could get confused and get demotivated. It also needs to be fun. That's of course important. This can provide motivation and entertainment. So you can kind of hide the rehab behind these types of games. And I think sort of layering on top of that, if we can actually incorporate other individuals, whether it's care partners playing the game with them, or even other stroke drivers across the country in sort of competitive social gaming, can be really, really helpful. In terms of the impact on patients, let me just give you some high-level numbers here at present. Since September of last year, when we fully launched the telehealth systems here, we now have around 700 individuals across the country who are engaging in this. And this is across 47 states. Right now, we've delivered almost 13,000 sessions. And in fact, it might be even larger than that now as I record this. And on average, is around 30 minutes per session. And during these sessions, we're able to deliver very, very high amounts of movements, active movements. And so right now, our averages are hovering around 40 movements per minute. This is equating to around 15 or 16 million movements that we've recorded right now, and which is really, really, really encouraging for understanding larger information about the recovery, such as predictive modeling and identifying which are the best strategies to induce changes. And of course, we've helped individuals gain autonomy and flexibility, and they're gain control of their capabilities to improve function. And so with that, I'd like to just quickly end and thank the team here. This is our core team that's helped develop this process and help to get all these devices out to the world. And so with that, I want to thank everyone for the opportunity to talk with you today, and I look forward to your questions.